want to welcome everybody to the May lecture in the Vermont monthly lecture series, Vermont Center on Behavior and Health monthly lecture series. And so this will be the last lecture in the spring semester, and we'll pick up again on September 18th, where we'll have a lecture from Sharika Danga from here at a member of the Vermont Center on Behavior and Health, and a cardiologist will be speaking on her research in women's health and cardiac health. But today, I'm really happy that we have Michele Staton with us. And I was just remarking to her how excited I am about her lecture. I was looking over her CV and her work, and she's doing really exciting stuff. But it aligns most closely with the work of Eli Klemperer in the VCBH. So I'm going to have Eli give a proper introduction. Oh, and then please do send questions as they arise in the Q&A link here that you have in front of you. And we will answer them at the end of Michele's lecture. Eli?
Thanks. I'm very excited to introduce Dr. Michele Staton today, who's giving the lecture. She is a tenured professor in the Department of Behavioral Science and a faculty associate of the University of Kentucky Center on Drug and Alcohol Research. Dr. Staton is a prolific researcher in the areas of women offenders, substance use disorder treatment, and the availability and access to treatment in rural settings. She currently serves as the PI on a number of NIH-funded projects, including the NIDA-funded Kentucky hub of the Justice Community Opioid Innovation Network, otherwise known as JCOIN. This center conducts research aimed at increasing utilization of medication to treat opioid use disorder among women during the transition from jail to the community. Her other projects are numerous, but include NIDA-funded research, which focuses specifically on HIV prevention in rural communities as women are exiting jail, and also increasing utilization of MOUD, specifically naltrexone, during the transition from jail to the community supervision in rural individuals with opioid use disorder. In addition to this, Dr. Staton is a mentor for several doctoral and master's degree students, and serves as an NIH ad hoc reviewer, an appointed editorial board member of the Journal on Rural Mental Health, and a review board member of the Journal of Social Work Practice in Addictions. She's also a member of the research advisory group for the Center for Excellence in Rural Health. So I'm very excited to have her come talk today. Thank you again for coming. And with that, I'll hand it over to you, Michele.
Well, thank you so much, Eli and Dr. Higgins, for that wonderful introduction. I'm so excited to be here today and to share a little bit of the work that we're doing here in Kentucky. We're going to specifically talk today about the work we're doing on JCOIN. And as Eli said, JCOIN stands for Justice Community Opioid Innovation Network. And so that's, again, mostly what we're going to talk about today. I am prepared to talk about 45 minutes or so, and then hopefully we can have some really rich discussion and conversation at the end. So again, thank you all for being here and for the invitation to talk today. I do want to start with, of course, an acknowledgement for funding for JCOIN through the National Center on Drug Abuse as part of the larger NIH HEAL initiative. I also want to start by just recognizing our team. This picture includes a lot of people from our partners at the Kentucky Department of Corrections, the Kentucky Department of Behavioral Health, to faculty members from 5 different colleges, 2 different universities, and a wonderful team there in the middle, as you'll see, which primarily includes women. And all women from different areas of Kentucky who collect data and provide the intervention for women in our study. So what is JCOIN? And let's just talk generally about sort of the larger cooperative to start. Again, it's a cooperative funded under NIDA with the overall goal of increasing the capacity of the justice system to respond to the opioid epidemic. And there's a shared vision for the different clinical research centers funded under JCOIN to increase access to evidence-based treatment for individuals who are in the criminal legal system, both during incarceration and as they transition to the community. With this overall plan of really building an intense network that includes researchers, administrators in both justice and treatment settings, as well as practitioners. Again, the main overall vision is that every individual who has a substance use disorder within the criminal legal system should have access to effective treatment, either while detained or as they transition to the community. And these are the goals of the larger cooperative, centered around new evidence for working specifically with individuals in this area, this network of researchers who collaborate very closely and intentionally with practitioners, and then becoming this go-to resource. And I wish I had time today. It could be a whole separate talk to just focus on the resources and trainings that are available out there through our Coordination and Translation Center. Building capacity again to conduct and apply research, working with criminal justice partners in criminal justice settings, and then increasing the translation, the speed of translation from science to practice. You can see here that the reach of JCOIN is pretty broad. Currently, projects which touch 38 states and Puerto Rico and 139 counties across the country. And this includes clinical trials, which are currently running in 28 states and 125 counties, a number of different pilot projects, dissemination studies, accelerator projects, and the RADx supplement, which had mostly to do with the speeding access to research and treatment around COVID. So a far-reaching project with a number of different types of projects running in each of these states. So there are 13 now, but this slide only shows the first 11 different clinical research centers which have rolled out under JCOIN. You can see that we have projects which focus on all kinds of different areas, like state policy rollouts around mandating MOUD in jails, to different types of opioid court models. The big block in the center is case management and peer navigation protocols, which is where our Kentucky hub is positioned. And then comparative trials with different types of medications in 2 different studies. There is also a juvenile JCOIN project, and lots of different studies which include this intersection between organizational intervention as well as client level intervention. So this is a quick snapshot of different protocols currently running across the country. And this doesn't even include, like I said, a number of different pilot studies which are funded under JCOIN, a number of different resources which are available. These are just the clinical research centers. So transitioning to what we're doing in Kentucky. We are the only JCOIN hub focused exclusively on women, and we're very excited about that. Our overall aim of the study is to implement a clinical trial under a type 1 hybrid effectiveness implementation design to look at the use of what we're calling pre-treatment telehealth. And we're going to talk a little bit more about that, both alone and in combination with peer navigation, to increase utilization of medications to treat opioid use disorder, or MOUD as we're going to refer to throughout the presentation. Again, focused specifically on women during the transition from jail to the community. Aim 1 is our randomized clinical trial, which we're going to focus primarily on today. Aim 2 looks at the different factors associated with implementation of this kind of trial in different types of jail settings as those settings partner with community providers. And then we do have a cost effectiveness aim. How much does all of this cost, and what are some of the offset and benefits associated with that? It's a big project with a lot of partners. I'm not sure how many of you have been to Kentucky. We're a relatively small state, but you can see from the different stars that our partners for the protocol run from far western Kentucky, which is Henderson County, to far eastern Kentucky, which is Pike County. That's about a 7, maybe 8-hour drive, depending on what kind of road conditions you run into. But a relatively small state with projects, again, ranging all across the state. The yellow stars are our comparison sites, which we're going to talk a little bit more about. The red stars are our experimental sites, and the green stars represent our MOUD partner providers. And we are centrally located there with the big UK logo kind of in the center-ish part of the state. Our peer navigation protocol is run by a local recovery center called Voices of Hope. They hire and train recovery coaches, peer supporter recovery specialists who are certified through our state. And they are, again, are centrally located in Lexington, but provide peer navigation services to women who are released in all of the counties reflected here. And this is kind of where our field offices are located, again, centrally in Lexington at UK, but also in Eastern Kentucky in our Hazard field office, and Western Kentucky in our Elizabethtown field office. So our randomized controlled trial, why are we focusing on women? Well, we know from the research literature that women are disproportionately affected by the opioid crisis due to a number of different reasons, a few of which include increased pain sensitivity, different prescribing practices for women, self-medication associated with different mental health or health conditions, and then a faster trajectory from exposure to opioids, from opioid use to opioid use disorder. We also know that the opioid overdose death rate has risen considerably for women in the last few years, considerably higher than that of men. And not to be confused with the number of overdoses is still considerably higher for men, but the overdose rate higher for women. Yet research around initiating MOUD among women has historically been relatively low compared to men, especially in justice settings where the population of men is just comparatively much higher. It's easier to run studies and to enroll large numbers of men. So research on women, despite having a number of unique vulnerabilities, a number of unique issues, has been largely neglected around MOUD specifically for women. And then why focus on the justice system in particular? Well, it provides a critical window, a critical opportunity to identify and intervene with women who are high risk, who for the first time in a long time might be abstinent from ongoing drug use. We know that the number of women incarcerated has, again, historically grown considerably in the last few years. And yet research in this particular area around barriers to initiation of MOUD and what are the specific factors that might be unique for women has really been lagging. So we're excited about this work, and we're learning so much through this JCOIN protocol. So this is what our clinical trial study design looks like. We randomly select and recruit women from jails in Kentucky, working with 9 different sites, as you saw in the figure earlier. 2 different arms represented in our experimental conditions, which sort of run down the left side of this figure. Our experimental sites are, again, 6 different sites across the state. We go into these jails on different days throughout the month, randomly select from women who are on site, screen for OUD, and then for women who meet eligibility criteria, conduct a baseline interview, and then randomly assign women to one of 2 conditions, either pre-treatment telehealth or pre-treatment telehealth with peer navigation. We're going to talk a little bit more about those in a second. Down the right-hand side of this figure are women in our comparison condition. These are women who are receiving services as usual in Kentucky. When we wrote this grant in 2018, there were 27 different jail programs across the state that received Department of Corrections funded, what they're called SAP programs, or substance abuse programs. Of those 27 programs, only 3 served women. And so those three sites, those 3 jails became our comparison condition. And at the time, they were able to, for women who met medical eligibility criteria, were able to receive an naltrexone injection prior to release from jail. So they're also screened using our same protocol, and they also do a baseline interview. So across all the conditions, once women are released from jail, we do follow them into the community at 3, 6, and 12 months post-release. These are our intervention components. Again, pre-treatment telehealth, everyone gets this in our experimental conditions, not our comparison group, but in our experimental conditions. And this is just a telehealth linkage with a community-based MOUD provider. It looks like a traditional psychosocial assessment that she would conduct if the provider would conduct if the woman walked into her office. But we're very interested in eligibility criteria for medications and how do we remove some of the barriers that might exist for that woman prior to her release from jail. So a one session psychosocial assessment focused on treatment opportunities with a specific focus on MIED. Again, both arms of our experimental group get pre-treatment telehealth, and then one arm also gets peer navigation services with our local provider. In this case, the peer also does a telehealth session with the woman prior to her release from jail. They mostly focus on recovery resources, recovery support, recovery capital, all the things that the woman has around her that might either impede or facilitate her entry into treatment. And then when they get out of jail, the peer navigator works with the woman for up to 12 weeks post-release to, again, really talk about some of those facilitating factors and barriers for entering treatment. And then again, we have our services as usual condition in the comparison group where women receive 6 months of substance use programming in the jail with the option of initiating naltrexone prior to release. So how things started. I'm not sure how many of you have actually implemented a NIDA cooperative, but it takes a little bit of time from getting the initial funding to getting measures in place across all the different protocols to make sure that we're collecting a core set of measures, to make sure that we have parameters in place around publications and what are some of the policies that need to exist. We had to establish a data safety and monitoring board that worked across all the different clinical protocols. So it actually took a minute to get started. We received the funding in July of 2019, and we received final approval ready to launch the study in February of 2019 or 2020. And we were at our first jail visit in early March when we got the notice from our governor that jails were closed due to the outbreak of COVID-19. So again, we were ready to go. We were ready to launch the study. Our jailer that we were meeting with was ready to go. And you can see, I thought this might be interesting in terms of how implementation rolled out. So again, we were sitting in the office of our first partner in mid-March. We didn't actually enroll our first participant there until December of 2020. And you can also see over in the far column in terms of enrollment method, we had to make a lot of changes. We had to make a lot of adjustments. Some jails were willing to let us come in. Those face-to-face sites almost were all Zoom at the initial time of enrollment until the later sites. But we did Zoom, we did interviews behind visitation glass, we did interviews across a confidential space in a conference room. At this point, we honestly began to just do whatever jails would let us do, and each jail almost had a separate protocol around COVID implementation. So lots and lots of challenges associated with all the COVID-19 restrictions in jails in Kentucky, jails honestly everywhere. So where are we now? I am really excited to talk about completing enrollment for this study. And in our intervention group, our experimental conditions, we enrolled a total of 600 women. You can kind of see this is a very busy consort. I'm going to sort of tie it all together and summarize it. But we randomly selected a little over 1,700 women in this condition, screened a little over 800 of them. Most of the 602 that were eligible for the study completed an interview, and then you can see how the randomization and allocation to different groups went. And this is towards the end of April. We're still tracking those jail release dates very closely because, again, that's what starts the clock ticking for our follow-up. So those are experimental conditions. We enrolled 600 women. We enrolled 300 women in our comparison group. We did randomly select women from treatment. We screened those women for eligibility. And again, most of those were eligible to participate. So this next table, I think, does a better job of kind of summarizing total enrollment across all the sites, across all the conditions. We did randomly select a little over 2,100 women for screening, screened a little over 1,100 of them, and about 76% of those women at the conclusion of the study met inclusion criteria. 900 women total enrolled, 300 comparison group, 600 experimental group. About 88% of those women, or the majority of the women, completed that pretreatment telehealth session while they were incarcerated. And again, with data towards the end of April, about 821 of those women at this point in time have been released from jail. So let's talk about what they look like. Again, we screened women who were randomly selected for indicators of opioid use disorder. We used two different tools to do that: the NIDA Modified Assist, which is represented in the top box, as well as the OUD checklist, which is the bottom box. For the NIDA Modified Assist data, we focused on both street opioids and prescription opioids. And for those of you who might not be familiar with the NIDA Modified Assist, ASSIST stands for Alcohol Smoking Substance Involved Screening Test, and it was initially validated by the World Health Organization in primary health settings to screen for the presence of substance use and alcohol and smoking. And scores on the ASSIST during that initial trial ranged around 7 to 8 for people in the general population. So you can see that our scores for women around opioid use were very high in this study, and a lot of high risk opioid use, which is you primarily get bumped up to the high risk category if you are injecting. So, and then the OUD checklist that is the DSM criteria for severity of opioid use disorder. And to screen into our study, you only had to have a 4 on the NIDA Modified Assist or a 2 on the OUD checklist. And you can see that's relatively low criteria, but our scores across each of those scales were very, very high. Now, I will also say, and I'll talk a little bit more about this at the end around a paper that we did ask a general open-ended one question: did you use any opioids in the year before you were incarcerated? So women had to say yes to that question in order to go on and be screened. So we knew that we were at least screening opioid users. Add that note here as well. So, on average, our women are a little over 37 years old. They're mostly white, which is reflective of our jail population in Kentucky. All 9 of our jail sites are located in either rural or suburban areas of Kentucky. We are not enrolling women from jails we really only have 3 larger urban areas in Lexington, Louisville, and the Northern Kentucky area. So I think that the demographic is very reflective of the population in those particular areas. About a third reported being married or living as married prior to incarceration. About 3/4 have a high school diploma or GED. Less than a quarter were working either full or part-time prior to incarceration. And most women reported either being currently covered by health insurance or covered before they came to jail. So again, we screened women into the study based on opioid use. So the top box really should not be much of a shock. So during the 90 days before they were incarcerated, most women were using some form of opioids. And that other category kind of captures everything other than heroin or fentanyl or the use of the non-prescribed use of medications to treat opioid use disorder. So other opioids in this category pretty much includes things like the misuse of prescription drugs. So while screening women into the study based on opioid use, you can kind of see that really what we have here is a sample of polysubstance users in general. They're using lots of different things. Meth use has really been on the rise in Kentucky for a while now, and really seeing it in this study in particular. So So a lot of opioid use, but a lot of other drug use as well. High-risk drug use has been described in our study as either injecting or history of non-fatal overdose. And again, in a randomly selected sample of women who screen eligible based on opioid use, you can see that about 3/4 of these women are or do have a history of drug injection, and a little over half have a history of non-fatal overdose. And again, those rates are higher than we would like for them to be during that 90 days before jail as well. So, in spite of the significant history of opioid use, only about half of the women have ever been prescribed any form of MOUD. And if you kind of scroll down there, you can see that's primarily buprenorphine. But a little over 3/4 of our women, almost 77%, have been in some form of substance use treatment in the past, which was encouraging for us to see. But very little treatment utilization in the year or 90 days prior to incarceration. So again, I mentioned that once women are released from jail, our follow-up clock starts to tick at for follow-up interviews at 3, 6, and 12 months. And this table just shows you a little bit about how that's going. In general, we have about an 88% follow-up rate. Women are released all over the state, despite us targeting certain jails in certain communities. So I attribute these are pretty good follow-up numbers, and I really attribute most of that to an amazing team who's very, very dedicated and very creative in terms of how to find people. So follow-up rates at this point are going really well. And based on sort of our work currently with the Data Safety and Monitoring Board, we aren't really conducting preliminary analysis on our primary outcome by group at this point. But we can say that about 21% of our sample overall has initiated some form of medication. Mostly the largest category there is buprenorphine. And while some people might look at that number and say, that seems kind of low to me considering the intervention, you also have to think about, again, these are women sitting in a jail cell who are not treatment seeking, and to just go in, randomly select women, talk to them about entering the study, it's a big leap to think about what happens then once they are released from jail. So we are encouraged by that number, but these are very raw overall sample numbers at this point, just to give you a sense of how things are going. And this is certainly a goal of ours over the next year, to really begin to try to understand these outcomes in conjunction with our Data Safety and Monitoring Board. Relapse to drug use, a little over a third, and relapse to opioids about 15%. So again, about 21% entering any form of MOUD, but we're also very encouraged about that 43.6% who entered any form of substance use treatment. Again, it's kind of a leap to think about leaving jail and initiating a medication intensive protocol like medications. And if someone will agree to go to outpatient treatment or intensive outpatient treatment or residential treatment, we're also really, really encouraged by that. So only about a 14% returned to custody, and about a little over 4% did report an overdose following release from jail. That number is much higher than we would like to see. I did want to talk a little bit in terms of what we're doing around overdose education in the JCOIN study. We have a reentry kit that we share once women complete the baseline interview with us. We leave a reentry kit that looks like this in their personal property. It just includes some basics. What are you going to need that first night that you get out of jail? And it also includes a Narcan kit. At the conclusion of our baseline interview with women, we show a video on overdose education and training. And once they complete that video, it really is, how do I recognize what an overdose looks like, and how do I take steps to protect someone or myself? How could someone take steps to protect me following an overdose? And so we leave those reentry kits, and we leave those Narcan kits in the reentry kit in their personal property prior to release from jail. Of the 300 or of the 663 women who've completed a follow-up interview with us, most of them reported that they received that naloxone that we left in their property. We did have some instances where jails just weren't cooperative in terms of making sure that made it into personal property. And then there's just other reasons we really just don't know what happened. But we did have 44 women who indicated at the 3-month follow-up that those kits were used. 14 different kits were used to revive participants in the study, and 30 kits were used to revive other people that were in their network somewhere between that baseline interview and that 3-month follow-up. We have also distributed a little over 1,000 kits at each post-release point during the study. We really encourage women to stay in touch with us and call us if you want another Narcan kit anytime. So we're tracking that very closely. We did have a case, we had 29 women again during that 3-month follow-up period who reported at least one overdose. And 93% of those were reversed with naloxone, either administered by a friend, a partner, or a neighbor. And then a few others reported use of the Narcan kit, either by a paramedic or an EMT. Heroin was the primary drug of use prior to that, but also high rates of fentanyl and methamphetamine as well. We have received some really positive feedback from those distribution of the Narcan kits from our project staff who've talked to women and said that they used the Narcan on a friend. She wanted to make sure I expressed how grateful she was to the study, and I left her another kit. Another project staff said she told us that our study participant reported that the kit saved her life. Her friend found it and gave it to her and literally brought her back to life. And then one of our MAD providers talked with a woman post-release and said, you know, you all are making a difference. One woman that I talked to told me that she would not be alive today if it weren't for the Narcan kit provided to participants. So we're happy about these findings, and we're excited to be able to distribute Narcan and provide overdose education. But that yellow bar is still a little higher than we wish it was. And so we're trying to think of more creative ways to interact with our justice system and with our community partner and with our women to get Narcan into to everyone's hands anytime that they need it. So that's a little bit overall about the clinical trials. Super quick, what are we doing around implementation? We are collecting data with a number of different folks involved in the study: MAD providers, jail staff, our peer navigation staff. That jail staff also includes higher level administrators within the Department of Corrections. So we want to really understand how this went, particularly in light of COVID and the use of telehealth. So we're doing qualitative and quantitative interviews at baseline, the midpoint of the study, and then we're currently now involved in the conclusion or endpoint data collection for the study. In terms of our economic analysis, we are working closely with Catherine McAllister and her team to look at startup costs for the project. How much did it cost to implement telehealth across each of the settings? How much does it cost to keep it running over time? And then how do those costs relate to and translate to costs around outcomes, especially relapse, overdose, and recidivism? And the use of medication and how that plays a role in the reduction, hopefully, of some of those outcomes as well. So I kind of consider this last part of the talk a bit of a data blitz. I just wanted to share with you some of the things that we're learning, some of the things that are unique, particularly for women, that we wanted to highlight. You can see one of the first papers that we put out was really to describe and profile our random selection process. And I think this paper reported that 98% of our women reported opioid use in the past year. Our final random sample ended up with that number being about 76%. But of those women who answered yes to that any use of opioids in the past year, only one did not meet our OUD criteria, either using the OUD checklist or the NIDA modified assist. So what we kind of learned from this is that if they are using opioids, they are using them at pretty high rates and at high risk profiles. And our street opioid use were particularly associated with high risk drug use like overdose and injection drug use prior to incarceration. We also know that women in particular have histories of violent victimization and mental health. And we knew that those rates were going to be high. And they're profiled in this paper at about 75% for depression, 64% anxiety, and about 78% traumatic stress, which is an indicator of PTSD. We also know that about 2/3 of our women reported at least 4 or more ACEs, and those are adverse childhood experiences, which were then correlated with different adult reported mental health problems. We also see in this study that self-esteem was a significant mediator of that relationship between ACEs and adult mental health. And so that becomes a really important intervention point for us. And how do we use self-esteem or think about self-esteem differently? But high rates of mental health, high rates of experiences of victimization and violence. Along that same line, we also looked at the relationship between some of those experiences and violent offending. The rates of violent offenders in this particular sample, again, all of our women were incarcerated in jails, and so we expected that that rate would be relatively low. We tend to see more violent offenses in prisons for women, but about 1 in 4 women were convicted of at least one violent crime in their life. And about 3/4 of those were diagnosed with some type of psychological disorder in their lifetime, any psychological disorder. And we know, again, that mental health diagnosis, interpersonal trauma were all significantly related to those histories of violent events. So again, some of the unique indicators that may be specific for women. We have also described our peer navigation intervention in some detail. We wanted to just sort of get the protocol out there and talk about that initial telehealth session between our peer navigators and our women. And they talked a lot about what their primary goal for treatment was. What's their primary goal when they get out? And about half of them said they wanted to go to treatment. Others just needed basic things. I need a place to live. I need clothes. I need to do some rebuilding of relationships with my family. They also talked a lot about stigma around MOUD, which was very important for us to learn, and how that affected some of those decisions about entering MOUD when they got out. And in general, they really valued that relationship with their peers and found a tremendous sense of hope in the process of recovery. And we learned very early in the study that there really aren't good measures out there to assess that relationship between a peer and a participant. So one of the first things that we started to work on with this grant was, how do we measure that? How do we assess that? And we started with a well-validated client assessment of self and treatment from our partners at TCU on their JCOIN partner. And we started to build some of those existing constructs around just that relationship within treatment, but what's unique about a peer. And so we did some focus groups with peers. We rolled out a survey with 100 folks who are currently working with recovery coaches, and ended up in a final analysis with 5 different domains of the relationship between a participant and a peer, between satisfaction, rapport, motivation, encouragement, role modeling, and community linkages, or the SPARK, Scales for Participant Alliance with Recovery Coach. And we're continuing to use this tool in our current JCOIN sample, which will be, again, much larger, and be able to work out some of those different issues and how they relate to other elements and aspects of recovery. I also wanted to draw your attention to a couple of exploratory presentations that we've done. The first was around sex trafficking and sexual exploitation, which has been, we've measured sex exchange among women, transactional sex among women for a long time. But the extent to which that could fall under the larger umbrella of sex trafficking or sexual exploitation, we really hadn't looked at. So, and this, we sort of give our NIDA partners some credit for this because they've been seeing that in some other studies, and they're like, you guys should be looking at this. And so sure enough, we know that about half of the women in our study reported ever engaging in some form of transactional sex. But of those, 38% or so had sex where someone else received the payment for that. About half had been either trafficked or exploited by force, coercion, or fraud. And then again, about 38% reported being forced, manipulated, or coerced into using alcohol before having transactional sex. So these are measures that we are continuing to evaluate, especially as they might relate to HIV or hepatitis C risk behavior, as well as continuing that relationship with high-risk drug use, injection practices, and those kinds of things. And again, as I mentioned earlier, we recruit women into our study based on opioid use, but we know that the majority of them are polysubstance users. And through a latent class analysis looking at opioid patterns in particular, we knew there would probably be these two groups which emerged, which isn't surprising. Non-prescribed use of medical or opioid drugs versus high rates of heroin or fentanyl use, so more street opioids versus prescription opioid misuse. And our street opioid users, our group 2, did score higher on measures of the OUD checklist, more likely to report overdose and injection drug use, and more likely to report co-occurring use of cocaine or meth prior to entering jail. So we're continuing to look at those trends and patterns as well as they might relate to different types of treatment entry or treatment utilization following release from jail. So what are we working on now? I thought it might be interesting to share that, again, some of the things that we have in process. We recently submitted a paper looking at protective factors among women. We always seem to think about what are the risk factors for things like drug use, like injection drug use. But this paper is focused on protective factors and what are some of the things that make women less likely to engage in some of these high-risk practices, more resilient over time. And how do we really understand those with an eye to thinking about future interventions? We also recently submitted a paper, as stigma is really a growing body of research right now, and we believe that women have some unique experiences that relate to their experiences of stigma. So this paper looks at what are some of the things that have happened to women over time that might increase their perceptions of stigma in different areas, anticipated, enacted, and what are some of those related correlates. We also have studied for a long time the importance of women's relationships in their initiation of drug use or their maintenance of drug use, their return to drug use, their relapse, their recovery. And so this paper really profiles a broader social network structure from family to peers to partners. What do those social network structures look like and how they function with regard to increased or decreased opioid use and treatment utilization? And then, of course, again, I mentioned the overdose concerns that we have with this particular study and looking at what are some of the correlates of lifetime and more recent overdose experiences and how do those differ among women from rural and urban areas. A planned paper is also to look at some of the benefits associated with our OEND protocol and looking more. We shared some of that preliminary data today, but looking more specifically at Narcan distribution following release from jail and its impact on reversing overdose and among whom. And then, of course, our ultimate follow-up paper will examine that MOUD utilization among our different groups of the intervention following release to the community. So that is all I have today, and I would love to open the floor to questions at this point.
Thanks for that wonderful talk. That was great to hear. It's just impressive all the work you're doing, especially just the breadth across your state, collaborating with that many states is wonderful. So I'm sure we have some questions in the chat, but I have a couple here that one in particular I'd like to start off with. I was struck by some of the numbers you put up. And if I read it correctly, it looks like about 85% of the sample you're recruiting is also using amphetamines or psychomotor stimulants. And I wondered if you could speak to at all any efforts to treat the co-use of psychomotor stimulants and opioid use among women who are leaving correctional facilities or jails into either rural communities or just re-entering communities in general. Whether your group is doing that or any other groups, be curious to hear your thoughts on that.
I'm trying to get back to that slide really quickly. I wish I had a really good answer for you. Other than continuing to hear it's a problem, I am not aware of any what I would consider current best practices or current emerging evidence-based treatments. It seems to be more of an issue of how you can tailor different types of behavioral interventions to address co-use, but that's something that we really want to look at in the data. Are there unique differences between women who report polysubstance use? But we have a sample of primarily polysubstance users, so I think that's kind of hard to at this point. But yeah, I'm not aware. What about you all? Are you doing anything in this particular space?
I also wish I had a great answer for you on that.
Yeah.
The short answer is not among people who are being released from incarceration.
Yeah.
Of course, Steve, could speak to all the work he's done over the years with contingency management and psychomotor stimulant use.
Yeah, I mean, that's the one reliable evidence-based treatment we have for psychomotor stimulant use. And certainly it's, some of the seminal studies were done with people who had comorbid opioid use disorder, Ken Silverman studies, for example. Yeah, I know we have some, at least two questions, one or two in the from the audience, and then I have a question for you. I was just curious what the policy is in Kentucky for starting medications, opioid medications while incarcerated.
Well, when we started the study, there were about 27 different jail programs and then somewhere around 12 different prison programs. And those are substance abuse programs managed and run by the State Department of Corrections for state inmates who are housed in those facilities. And if you completed that 6 months of DOC funded treatment, and you met medical criteria for opioid use disorder, you had the option to receive a naltrexone injection prior to release to the community. And when we started the study, that was all that was available to you in the state.
Mm-hmm.
But in the last 2 to 3 years, the Department of Corrections has really revamped that policy considerably. And people who initiated that Vivitrol injection prior to release were eligible for what they called good time. So there was an incentive in the community for initiating the medication. And they basically have shifted completely away from that model and now offer all 3 forms of medication, at least buprenorphine and naltrexone. Methadone, I think, is still in the onboarding process, and they've expanded it to individuals beyond just people who are receiving treatment. So our state has really undergone some considerable changes in this space. They've shifted to much more of a medical model where all of the distribution of medication is managed by the medical teams within those facilities. It's been a little quicker to onboard in prisons because DOC, of course, runs those medical facilities. Most of our jails in the state still contract with medical providers from the community, so that's been a little slower to uptake.
Mhm.
But really, really proud of that shift in the state in recent years.
Yeah, I'm happy to hear that. Complication for your study, or unfortunate
Yeah.
that it came after you started, but what an important change for the population. So great.
Yeah, and we are monitoring that. We've been keeping it kind of as part of our implementation protocol to keep up with dates when those were implemented at the facilities and impact. And we have been trying to stay on top of that. But yeah, it's an interesting thing to be happening right along with the study. But such is research and working with corrections.
I don't know from experience the corrections part, but I could just imagine. But you are in maybe a good position, like you said, to get some evaluation of how that's changing what you see, or how it corresponds to the changes in policy and what you're seeing. So
Yeah.
that might be a nice feature.
And again, with 900 women, we also know like who enrolled in the study at what point. And so we will be able, and we ask questions that follow up around where you offered medication and by whom and when. And so and then we have access to those administrative records as well. So it is an interesting opportunity for sure. So.
Chris, do you want to read a couple of the questions from the audience?
Yes. Jessica asks, are you hearing concerns from law enforcement about diversion of MOUD, especially methadone, after individuals are released?
We, as the study, are not hearing any concerns from law enforcement, but I will say to you that, again, through our implementation protocol, we are working very closely with jail administrators, our State Department of Corrections, and there is concern. I mean, obviously, there is concern about that, but the medication is delivered on the inside, so they wouldn't necessarily have access, to taking the medication into the community. So I think the concern is more, would the medication be diverted on the inside, and how do they control for that? That increases lots of concern. And then, how do we manage people on this kind of medication? So.
Okay. And Susan asks, it looks like you had a very high follow-up rate. What do you think contributed to your success in getting people in for follow-up interviews?
I think it's a great question, and I'm so proud of our team for this. So I think part of what I would attribute that to is 20 plus years of working with this population and trying to keep up with them when they get out. We have probably modified our locating and tracking tool many, many times over the course of time. And oh my gosh, we learned that if we know where mom is, we're more likely to know where she is. Or if we know where grandma is, we're more likely to know where. So we need to make sure we get addresses for mom and addresses for grandma. Partners are the worst people on the planet to get any contact information from. If we can only get a cell number for a partner, we know we're going to have a hard time finding that woman. But I will also say that social media has become a tremendous resource for us. We had an R34 a couple of years ago where we implemented a Facebook HIV prevention intervention, and some consultants who were working with us to develop the protocol were like, so Facebook is on its way out. Nobody uses Facebook anymore. But our women were telling that we use Facebook. I mean, if I'm incarcerated, I make sure my mom manages my page so everybody knows where I am and why I'm not posting. And so they really get excited about social media. Some of them might have 5 or 10 different accounts, and that's hard to keep up with. But the social media has been a huge resource for us. And we do some of our follow-up interviews by we do a lot of our follow-up interviews by phone. That really started during COVID. Sometimes people don't have an actual phone, but they have Facebook, and they'll do a Facebook audio call with us to do their follow-up. So social media has been a huge benefit for us. And I also really attribute a lot of that success to our staff. They collect a lot of locating and tracking information, work really hard to build rapport with these women before they're released. So I think that's also really important.
Great. Looks like Jessica has a follow-up question, and she's asking if MOUD is administered in the jail, are you able to hear from participants what it's like for them to try and access those medications once they're released? And are they facing any barriers to continuing their MOUD treatment?
That is a great question. We do know that the Department of Corrections has really good resources in place. So if a woman is on a medication when she leaves jail, she should know where to go to continue that medication. But sometimes what we learn is that it's not just access to the medication, it's things just change when you get out of jail. You begin to interact with family who thinks this is a bad idea, or you begin to maybe work with a parole officer who sadly thinks this is a bad idea. Or, you know, there are lots. We published a paper. I'll send it to Eli, and maybe you can share it as part of the follow-up. But we published a paper on some of the facilitating factors and barriers to utilizing MOUD in the community. And those are some of the things that really came up. So we often think about some of those structural barriers, like, do I know where to go and can I afford it, and those things. But sometimes it's just a lot of other life stuff that really can play a role in that.
Excellent. Well, if there are any last minute questions in the audience, please send them in. We have a couple minutes left. Yeah, that's that. Go ahead, please.
We have one from Amanda, and she says she observed a great deal of stigmatization towards folks using MOUD in correctional facilities, like you just mentioned, even at times from healthcare providers. So I really appreciate your efforts to shed light on this. What interventions or new directions would you like to see regarding the stigma?
I think that is a great question. We in our state currently are working on a training video, which really spun out of a lot of different factors, but stigma really emerged as one of these major barriers to people making that first phone call to treatment or staying in treatment when they get there. And so I am not a video producer, and this is way outside my wheelhouse, but we have loved talking to people all across our state about how do we do this differently. But yeah, and it's sad to hear that even among healthcare providers, there's a lot of stigma around the utilization of it. Even among substance use treatment providers, there's a lot of stigma sometimes. So again, it's one of those, I wish I had a really good answer to that, but we just keep working on it. Training, I think, is really important. Education is really important, and hearing from the voices of people that how they feel about these things. Because I think sometimes we experience stigma and we just don't talk about it. And I think that's really important.
Well, I think that is all the time we have. So, Michele, thanks for really a informative and exciting presentation, and I feel like I've learned a lot from hearing it, and I suspect others do as well. So thank you very much. And to the audience, please join back in September 18th when we kick off the fall 2024 VCBH lecture series with Sherry Kadanga. So thanks to everybody, and we'll see you in September.
Thank you all so much. It was a pleasure to be here today. Thank you.